Hello, everybody. My name is Aman Chauhan. I'm a medical oncologist. I lead our neuroendocrine cancer program at University of Miami and also co-direct a theranostics program. Today, I would be talking about a very exciting and the latest study for high-grade neuroendocrine cancer. It's a phase one, first in human study, which going to be testing a new drug called Seneca Valley virus in combination with immunotherapy or immune checkpoint inhibitor, ipilimumab, nivolumab. I know it's a mouthful, so I like to call it Ipi-Nivo. All right, let's prime the audience regarding the target patient population for this study. When I see a neuroendocrine cancer patient in my clinic, it's very important for us to understand what type of neuroendocrine cancer are we dealing with. As you probably already know, there are two main varieties of neuroendocrine cancer, the NET, well-differentiated neuroendocrine tumor, and NEC, poorly differentiated neuroendocrine carcinomas. They sound very similar, but they are very different diseases. Within NET category, there are three varieties based on grade of these tumors, grade 1, grade 2, and grade 3. Neuroendocrine Cancer Foundation has a wonderful primer and one-on-one lectures on these classifications and nuts and bolts of neuroendocrine cancers. I would encourage you to review those to familiarize yourself with the terminology. But the reason why I am showing our audience this is this particular clinical trial focuses on high-grade neuroendocrine cancers. That means a grade 3 cancers. And it's going to include both, as you can see, well-differentiated grade 3 neuroendocrine tumors and also poorly differentiated neuroendocrine carcinomas, which by definition are always grade 3. Grade 3 cancers, be it well-differentiated or poorly differentiated, are somewhat aggressive cancers, definitely much different disease trajectory and tumor growth rate as compared to low-grade or intermediate-grade well-differentiated neuroendocrine tumors. And these cancers, unfortunately, are also a critical unmet need and needs better and improved treatment options. Here in front of you, you see survival plots for different type of neuroendocrine cancers. And as you can see, the line on the top are survival curves for a well-differentiated low and intermediate grade 1, grade 2 neuroendocrine tumors, and the median survival is in years. And some patients go on to live decades as compared to well-differentiated high-grade neuroendocrine tumor in the blue and poorly differentiated high-grade neuroendocrine carcinoma in the red have a significantly shortened median survival. This is very important for us to appreciate as a drug developer, scientist, who are focusing on next generation of clinical trials. This is the problem area where we need to improve the outcomes of our cancers and develop and invest in better treatment options. Similar trends we also notice in small cell lung cancer. Lung cancer, there are different types of lung cancer, adenocarcinoma, squamous cell carcinoma, small cell lung cancer, which is about 14 to 15% of all lung cancers. Small cell lung cancer is a high-grade, poorly differentiated neuroendocrine carcinoma of lung. And the line on the bottom, the yellow line on the bottom, that's a survival of small cell lung cancer. And 5-year survival at present are in the range of 10 to 15%. We certainly need to do a lot better to help our small cell lung cancer patients and small cell, large cell neuroendocrine cancer patients, regardless of the site of origin. We need to help them improve their outcomes. Now, they say pictures speak 1,000 words. These are some of the patients who unfortunately have succumbed to high-grade neuroendocrine cancers. This is not a cancer of a particular age group. I've seen kids as young as 10-year-old with poorly differentiated neuroendocrine carcinoma. young patients, um, cross the spectrum, walks of life. Um, Age does not matter. Socioeconomic status does not matter. And these high-grade neuroendocrine cancer can stem out from many organ systems: cervix, ovaries, colon, rectum, pancreas, stomach, esophagus, lung, you name it. So with that in mind, I've been trying for past several years to focus on drug development for high-grade neuroendocrine cancers. And one of the concepts that I've been working on for past several years is an oncolytic virus-based concept called Seneca Valley virus, and I've been trying to combine it with immune checkpoint inhibitors. So let's understand what Seneca Valley virus is. SVV, short for Seneca Valley virus, is an oncolytic virus. What does that mean? These are the viruses that like to infect the tumor cells and destroy them. Oncolytic. Oncology, a cancer cell, lytic, destroys it, lyses it, damages it. So it physically infects the tumor, grows within the tumors, and literally bursts the tumor open, and then goes on to infect another tumor, and so on and so forth. One of the cool things about this particular oncolytic virus is it is not, it does not cause any infection or harm to normal host cells, which is very, very important. It only causes damage to cancer cells. Now, this virus has been in development for a while, and there have been a few studies done in the past. However, what we didn't realize that it has a specific marker called TEM8, and you can screen a cancer for that particular biomarker. So if the cancer cell expresses TEM8, it's a sort of like a landing pad for the virus. So TEM8 positive cancer cells attracts this virus and latches onto it, and the virus is able to enter the cancer cell much more efficiently if they're TEM8 positive. And this TEM8 is actually seen in various cancers, including high-grade neuroendocrine carcinomas and well-differentiated neuroendocrine tumors. And that's where my interest in developing SVV in neuroendocrine cancer lies. I've been working very closely with Seneca Therapeutics for past several years in developing this concept, bringing it to our high-grade neuroendocrine cancer patients. As I was mentioning before, this virus has a lot of good science behind it. Some of the early work was done at Memorial Sloan Kettering at Dr. Charlie Rudin's lab, where he tested this virus in small cell lung cancer models, had a very good data to support its anti-cancer activity. However, early human studies, although confirmed safety, there was no safety concerns, did not show very promising anti-tumor benefit. And the reason was at that time, we did not know about TEM8. We did not had a screenable biomarker. Secondly, the virus was injected through IV and just one dose. Since then, we have learned that these oncolytic virus-based therapies are better suited if we inject it directly into the tumor, because when we infuse them in through IV, our body generates antibodies to neutralize this oncolytic virus and gets rid of it within a week or two. So in last several years, we have learned the things that will make these viruses infect cancer cells more efficiently so they can thrive within the cancer cell and literally destroy them. Moreover, what we have, and this slide here is from some of the earlier phase 1 studies done with Seneca Valley virus, and showing some anecdotal evidence that even with single dose, even with Seneca IV administration, there were patients who had a very good response and had disease stabilization with Seneca Valley virus. However, the real merit of this concept lies in the combination part. Now, we've been using immunotherapy, and these are class of drugs that have revolutionized cancer treatment for several cancers, melanoma, kidney cancers, lung cancers, but has not had a great footing in neuroendocrine cancers. High-grade neuroendocrine cancers, however, can respond to immunotherapy. This is a patient of mine, as you can see, before and after Ipi-Nivo. Uh, it was transformative. The tumor literally disappeared. I wish to see each patient have this kind of response. Unfortunately, it's a very small minority high-grade patients who respond to immunotherapy this way. Why do most patients not respond to immunotherapy this way? It's because neuroendocrine cancers are quote unquote cold tumors. They don't have enough antigens, or they don't not generate immune response when we give immunotherapy to them. So the trick here is to convert these cold tumors into hot, make them immunogenic, so that when we administer immunotherapy, they engage immune system to fight against these cancer. How are we going to do that? You probably guessed it. We are going to do that by injecting Seneca Valley virus into the tumor and making these cold tumors hot. How do we know that it works? Well, we have a proof of the concept in animal cancer models. As you can see here, the line in the bottom, the red line, that is SVV, Seneca Valley virus, plus Ipi-Nivo sort of drugs, anti-PD-1, anti-CTLA-4 drugs. And you can see the cure rates. Anytime we injected the Seneca Valley virus and then gave the animal Ipi-Nivo equivalent immune checkpoint inhibitors, we saw massive improvement in tumor reduction, disease control rate, and cures. That is what we really aim to now achieve in humans. So we have good rationale. Theoretically, we have very solid animal data. This is the data that I personally presented at one of the NANETS meeting a few years back. And this also goes on to show drug development takes time, takes patience, especially to kind of do it safely and make sure that it is not hurting our patients. So we now are at a stage that we have launched this first in human phase 1 clinical trial at University of Miami. It's a labor of love, and I'm very glad that it's now up and running and available for appropriate patients. The key goal for the study is to look for what would be that safe dose of Seneca Valley virus that can be combined with standard of care Ipi-Nivo dose. Also, we would like to understand the amount of anti-cancer benefit in terms of median progression-free survival, response rates, that means shrinkage we see on the scans. And we also have a lot of interesting science built into it because we would like to understand mechanism of action, mechanism of resistance with the help of biopsies at an appropriate interval in certain select patients. This slide shows us the study schema. So being a phase 1 study, we start off with relatively lower dose of Seneca Valley virus in the dose level 1. Once patients do well with that dose, we treat next few patients with a little bit higher dose, and then next few patients a little bit higher dose. And once we have achieved the dose level 3 safety and tolerability, then we're going to treat patients with multiple doses. And this is where we want to land, because we believe that it's not just one dose, it's going to be multiple doses every 2 weeks for up to 6 doses. That's going to build enough oncolytic virus in the system to help us fight the cancer cells. Patient will get immunotherapy with Ipi-Nivo per standard of care, that what we use as prescribed by NCCN guidelines at present for high-grade neuroendocrine cancers. Key inclusion and exclusion criteria. I will not bore you with the details here, but anybody who has high-grade neuroendocrine cancer, that means grade 3 well-differentiated neuroendocrine tumor or poorly differentiated neuroendocrine carcinoma of any site, has had at least one line of prior therapy. Most of the times, this would include a cytotoxic chemo like carboplatin etoposide, FOLFOX, FOLFIRI. At least one prior line of therapy is needed and have a good performance status can participate in the study. Unfortunately, the study is only available at University of Miami, so is willing to travel and is feasible for the patient. Those are some of the key inclusion exclusionary criterias, but on consenting, we take a deep dive and look into fine details if there are any concerns in patients' participation. For details, you can also find for more information on study at clinicaltrials.gov. With that, I would like to thanks all of you for tuning in, and especially Neuroendocrine Cancer Foundation for giving us this opportunity to tell the audience about this new clinical trial focusing on high-grade neuroendocrine cancer. That's our team, collaborators, scientists, and that's some of Seneca Valley Wire's sponsors. Dr. Hallenbach was a founder of the company and also the one who did most of the preclinical work along with us. Thank you so much, and till we meet again.